morning, everybody. How are you all? Hope all of you are staying safe at home by the grace of Almighty. Today's topic allotted for me is chemotherapy of fungal infections. This topic is a large topic, so it is divided into two parts. So today I want to deal with the part one. The fungal infections are before 1950, they were less prevalent. After 1950, because the invention of the large antibiotics, the fungal infections are more prevalent because of the use of the antibiotics. And in immunocompromised patients, and also use of the corticosteroids and anti-malignancy therapy. So these infections are divided into two parts: anterior, that is superficial fungal infections, and deep fungal infections. Actually, the fungus are available as four types: yeast-like fungi, filamentous fungi, and dimorphic. Yeast-like, the example for yeast-like fungus are Cryptococcus neoformans, and yeast-like fungi are Candida. The common name for Candida is Monelia. And the third type is filamentous fungi. These are appearing as filamentous forms. Examples are Aspergillus fumigatus, Trichophyton, Epidermophyton, and Microsporum. Coming to the dimorphic fungi, these are having both structures, that is yeast-like and filamentous, depending upon the nutrition. If the nutrition is more, they will appear as filamentous form. If nutrition is not sufficient, they are available as yeast. Example for dimorphic fungi are Histoplasma capsulatum, coccidioids, and blastomyces. And coming to the cell structure of the fungi, these fungi, they will prepare their cell wall because the availability of the enzymes present inside the cell body. So they will prepare the cell wall. The cell wall consists of beta glucans and chitin and ergosterol. Ergosterol is the main constituent of the cell wall of the fungi. In humans, cholesterol is present, but in fungi, ergosterol is present. This ergosterol is synthesized by the fungal cell with the help of acetyl coenzyme A. Acetyl coenzyme A, from the acetyl coenzyme A, squalene is prepared, and squalene is converted into lanosterol with the help of squalene epoxidase. This lanosterol is converted into ergosterol with the help of 14 alpha lanosterol demethylase. And this ergosterol, it is incorporated into the cell wall. So the cell wall consists of ergosterol, beta glucans, and chitin. This is the these three compounds, they will maintain the integrity of the fungal cell wall. And the microtubules also present within the cell wall. The DNA synthesis occurs because of the nucleic acids. Then this is the structure of the fungal. So why I am telling this structure of the fungal cell is the drugs which are used in the fungal infections are, they are acting on the each and every point of the cycle, cell wall synthesis cycle. So you should know what is the cell structure and what are the enzymes present in the fungal cell wall, especially the cell wall, that is beta glucans. Some drugs, they will interfere with the synthesis of the beta glucans. Some drugs, they will interfere with the microtubule formation, and some drugs, they will inhibit the squalene epoxidase. And other drugs, they will inhibit the 14 alpha lanosterol demethylase and inhibits the synthesis of the ergosterol. In turn, it will inhibit the synthesis of the cell wall. So coming to the infections, there are of two types: superficial infections. They are also known as superficial mycosis. And second one is systemic infections or deep mycosis. The examples for superficial mycosis are candidiasis, monelia. The candidiasis also known as monediasis. Second infection, superficial example for superficial infection is dermatomycosis. That is, common name is ringworm infection. It includes trichophyton, epidermophyton, and microsporum. Examples for deep infections are aspergillosis, blastomycosis, candidiasis, cryptococcosis, histoplasmosis, mucormycosis, coccidioidomycosis, and paracoccidomycosis. Coming to the drugs, these drugs are classified according to its chemical structure, and they are also classified according to their mechanism of action. Coming to the classification of drugs based on chemical structure, number one, antifungal antibiotics. These are again divided depending upon the structure. They are again divided into polyene antibiotics, heterocyclic benzofuran, and echinocandins. The example for polyene antibiotics are amphotericin B. Amphotericin B is used for systemic infections, whereas harmycin and netamycin, they are available for topical use for the superficial infections. Coming to the heterocyclic benzofuran group, the example for it is griseofulvin. It is used for systemic infections, that is deep infections. And next group are echinocandins. Example for echinocandins are capsofungin. That is, it is used for the systemic infections. Coming to the second group of drugs, that are azoles. These azoles, depending upon their chemical structure, azole ring is having two nitrogen molecules. If two nitrogen molecules are there, it is comes under imidazole group. And if the other, that is, three nitrogen molecules are present, it will comes under triazoles. So azoles are divided into imidazoles and triazoles. The examples for imidazoles are ketoconazole. This ketoconazole is used for both systemic and topical. That is superficial infections. It is meant for both infections, available as systemic and topical use. And coming to the other drugs are clotrimazole, meconazole, iconazole, ticonazole, and sulconazole. Also oxyconazole. All these are used for the topical infections, that is superficial infections. Next group of drugs are the triazoles. What are the drugs comes under triazoles are terconazole. Terconazole is used for topical infections, whereas the other drugs which comes under triazoles are used for the systemic infections. What are the other drugs? Fluconazole, itraconazole, voriconazole, and posaconazole. So third group of drugs are the fluorinated pyrimidine derivatives, that is flucytosine. Fourth group of drugs are the allylamines. The drug comes under allylamines is terbinafine. This terbinafine used for both systemic and topical infections. Other group of drugs are the miscellaneous ones. These are used only topically. What are the drugs? Cyclopiroxolamine, haloprozine, tolnaftate, naftifine, and butinafine. And coming to the classification based on mechanism of action is number one, cell wall synthesis inhibitors, that is caspofungin. Second group is increasing cell membrane permeability. The drugs comes under this group are amphotericin B and nystatin. Third group of drugs are the ergosterol synthesis inhibitors. So under this, they are divided into two types, A and B. A is the drugs which will inhibit the enzyme 14-alpha lanosterol demethylase inhibition. So what are the drugs comes under this group are imidazoles and triazoles. Examples for imidazoles are ketoconazole, meconazole, and the examples for triazoles are fluconazole, voriconazole. Coming to the drugs which inhibit squalene epoxidase enzyme. This squalene epoxidase is important for the conversion of the squalene to lanosterol. So the drug is terbinafine. Fourth group of drugs are the nucleic acid synthesis inhibitors. That is 5-fluocytosine. Fifth one is the mitosis inhibitors. That is mitotic division inhibitors. That is griseofulvin. And coming to the individual drugs, before coming to the individual drugs, the mechanism of action of the drugs. That is the griseofulvin will inhibit the microtubular formation, whereas fluocytosine, it will inhibit the DNA synthesis, and amphotericin B and caspofungin, that is echinocandins, they will inhibit the synthesis of the cell wall. And the azole, that is azole allylamine group are inhibited. The allylamine group will inhibit the squalene epoxidase enzyme, so that the lanosterol synthesis is inhibited by allylamine, that is terbinafine. And coming to the azoles, they will inhibit the 14-alpha lanosterol demethylase. That is so that the lanosterol is not converted into ergosterol by azoles. This is the diagrammatic representation of the mechanism of action of the antifungal drugs. Then coming to the individual drugs. That is, the first one is the amphotericin B. It is a polyene macrolide compound. Polyene means consists of multiple number of unconjugated double bonds. So it is obtained from Streptomyces nodosum. It is having 7 unconjugated double bonds at one end, and the other end it is having hydroxylic groups. Hence, it is having amphoteric in nature. What is amphoteric? It is either soluble in lipid or soluble in water, both. So, coming to the mechanism of action, these unconjugated double bonds, they will form the exterior of the pore. This amphotericin B, it forms pores at the cell wall. So the unconjugated double bonds, they will form the exterior of the pore, and hydroxylic groups, they form the interior of the pore. This drug is highly toxic on parenteral administration. Coming to the mechanism of action, it binds with the ergosterol and forms pore or channel, in which the hydrophilic side forms, I already have told you now, hydrophilic side forms the interior of the pore, and the affinity of the ergosterol towards, and the affinity of the amphotericin B towards ergosterol is 500 times more than the cholesterol. So it is having more affinity towards the fungal cell, not with the human cell. Human cell consists of cholesterol, whereas the fungal cell, it is having ergosterol. It causes increased permeability of the cell membrane. Because of this increased permeability, there will be leakage of small molecular cellular contents like amino acids and others. It is fungistatic at lower doses and fungicidal at higher doses. That is, it can inhibit the growth of the fungus at lower doses, whereas it can kill the fungal cell at higher doses. This is the structure of the amphotericin B. It is having pores. The amphotericin B, it is the structure of the cell wall of the fungus. This amphotericin B molecules, they forms pores in the cell wall of the fungus, and through these pores, the ions, amino acids, they will enter outside they will leak from the cell, and they will enter to the exterior of the cell, so that the cell will die. Coming to the spectrum of activity, It is a broad spectrum antifungal and it is having broad spectrum antifungal activity. It is effective against Candida species, Cryptococcus neoformans, Histoplasma capsulatum, Blastomyces dermatitis, Aspergillus species. It has significant activity against dermatophytes, but not used because of its concentration achieved in the skin is low and inadequate. It has good activity against leishmania, but no antibacterial activity. Why? Because these bacterial cells, they are not having either cholesterol or ergosterol. Coming to the pharmacokinetics, oral absorption is negligible. So used for the treatment of candidiasis of the gut. It is not absorbed through the gut, so it will stay in the gut and it helps in the treatment of the candidiasis infection of the gut. Amphotericin B is available as complex with deoxycholate. So amphotericin B deoxycholate complex is a suspension prepared with the help of bile salt deoxycholate and a buffer, that is sodium phosphate. So this is a conventional amphotericin B preparation. The drug is released from the deoxycholate complex and widely distributed in the body. Before entering into the body tissues, it has to be released from the deoxycholate. Deoxycholate is a bile salt. So the drug has to be released from the deoxycholate and then it will enter into the tissues. So it is widely distributed in the body tissues. The 90% it is bound to the beta lipoproteins and its T half is 15 days and it is metabolized in the liver. That is only 2/3 is metabolized and 1/3 is concentrated in liver, spleen and little in the lung and kidney. Because it is concentrated in the liver and spleen, it is used in the treatment of visceral leishmaniasis and the drug is excreted through bile and urine. So this drug is having enterohepatic circulation. Why? Because it is apart from urine, it is excreted through bile. So it is having enterohepatic circulation. Coming to the lipid formulations of amphotericin B. This conventional amphotericin B is highly toxic. It is having highly nephrotoxic and it will lead to anemia. So the lipid formulations are prepared. These lipid formulations are having less adverse effects but these are very costly. But these are the drug of choice for the chronic infections and where conventional amphotericin is intolerable. The active drug is in lipid formulations. The active drug is packed in lipid delivery vehicles such as lecithin, cholesterol sulfate, and biodegradable phospholipids. They increase the delivery of the amphotericin B in reticuloendothelial cells, that is liver and spleen, apart from the site of infection. So these lipid formulations are used to treat visceral leishmaniasis. The other name for visceral leishmaniasis is Kala Azar. Coming to these lipid formulations, L-amphotericin B, that is liposomal amphotericin B. These liposomal amphotericin B will occur as pairs or vesicles. And the drug present in liposomal amphotericin B is only 10%. And the dose is 1 milligram per kg body weight. Coming to the ABLC, that is amphotericin B lipoid complex. Amphotericin B lipid complex. This drug is available as discs and the drug available in amphotericin B lipid complex is only 50%. The dose is 5 milligrams per kg body weight. The third liposomal compound is amphotericin B colloid dispersion. That is, it is available as ribbons and the drug is only 35%. The dose is 5 milligrams per kg body weight. The conventional amphotericin B is available as missiles and the drug present in conventional amphotericin B is 1 milligram per kg body weight. The lipid formulations are effective in deep mycosis but much costlier, and liposomal formulations are much costliest. Costliest one is liposomal amphotericin B. Coming to the therapeutic uses of the amphotericin B. Is used for systemic fungal. In first one is the for systemic fungal infections. The route of administration is IV route. In systemic fungal infections, number one, drug of choice for mucormycosis, invasive aspergillosis, extracutaneous sporotrichosis, cryptococcosis, candida esophagitis, and cryptococcal meningitis. In cryptococcal meningitis, it has to be used along with the flu cytosine. It should not be used alone. Why? Because it will develop resistance. And amphotericin B colloid dispersion is preferred for invasive aspergillosis who can't tolerate or who couldn't respond with the conventional amphotericin B. Means the second one preferred in cases of blastomycosis and coccidiomycosis and paracoccidiomycosis in immunocompromised patients, or if the lesion is rapidly progressive, or if involvement of the CNS is there. Usually for these infections, imidazoles or triazoles are the drug of choice. These imidazoles and triazoles are less toxic. Third one is the prevention of relapse in cases of cryptococcosis and histoplasmosis in AIDS patients. It should be used once in a week. This conventional amphotericin B is available as powder form, that is 50 milligrams per vial. It should not be introduced like that. It should not be given as it is. It has to be dissolved in 10 ml of distilled water, and then it has to be mixed with 5% dextrose to prepare an infusion of 0.1 milligrams per ml. And it should not be used it should not be used as it is. Why? Because it is highly toxic. It has to be given after the test dose. How the test dose has to be given? 1 milligram of infusion solution, that is 10 ml of infusion solution, is administered for 20 to 30 minutes. If there are no reactions, then the dose has to be increased. That is 0.25 milligrams per kg body weight per day over 2 to 3 hours. And the dose has to be gradually increased up to 1 milligram per kg body weight. The dose required is 2 to 4 grams over a period of 2 to 4 months. For oral route, it is given as 50 to 100 milligrams QID for intestinal moniliasis. Why? Because it is not absorbed through gut. It is retained in the gut, and it is used for the intestinal moniliasis. It is topical. It is used topically for vaginitis. And also for the otomycosis. For otomycosis, it is used as 3% eardrops. Second one is the superficial infections. All the infections which I have dealt are the deep mycosis. Coming to the superficial mycosis, this drug is topically used for cutaneous, oropharyngeal, and vaginal candidiasis. And for endophthalmitis, it is used intraocularly. As eye drops, it is used for the corneal ulcers and keratitis. As ear drops for otomycosis. And for bladder irrigation, it is used in the treatment of candida cystitis. Third one is the for febrile neutropenia. In febrile neutropenia, if it is not responding to antibiotics, it can be effective. The mechanism of action here in treating febrile neutropenia is not known. The fourth one is the leishmaniasis. That is especially for the visceral leishmaniasis and mucocutaneous leishmaniasis. Coming to the adverse effects, it is highly toxic. Its adverse effects are divided into two types. That is toxicity due to IV infusion and toxicity due to prolonged use. Coming to the toxicity due to IV infusion, it is the most common acute reaction. That is reaction like fever, chills, muscle spasms, vomiting, headache, and hypotension. This hypotension is because of the release of the cytokines, interleukin, and tumor necrosing factor alpha. Amphotericin B colloid dispersion is having most toxicity when compared to conventional amphotericin B, and it is less toxic than highly toxic than amphotericin B liposomal complex, and liposomal amphotericin B is least toxic. And this drug can lead to phlebitis, bronchospasm, and anaphylaxis. This bronchospasm and anaphylaxis are very rare. Hypoxia and hypotension are more troublesome in cardiac and pulmonary diseases. This can be minimized by reducing the dose of the drug or rate of the drug and pre-medication with antipyretics, antihistaminics, and corticosteroids. Coming to the second toxicity, that is toxicity on prolonged use. It is highly nephrotoxic. So 80% azotemia will occur, leads to hypokalemia, hypomagnesemia, reduced GFR, and renal tubular acidosis. Renal toxicity is minimized by prior or simultaneous administration of the adequate amounts of sodium and monitoring of potassium and magnesium. Renal tubular necrosis is irreversible if the dose is more than 4 grams. So the dose should not be exceed over 4 grams. And anemia. This anemia is due to reduced production of the erythropoietin by the kidney. Because of the nephrotoxicity, production of the erythropoietin is less. So it will lead to anemia. CNS effects and hepatic damage may occur, but rare. Coming to the drug interactions. This amphotericin B will lead to drug interactions. Like number one, facilitates entry of flu cytosine into the fungal cell and thus increases the activity of each other. So amphotericin B facilitates the entry of flu cytosine, and this flu cytosine also helps in the entry of the amphotericin B. And rifampicin and minocyclines, they will potentiate the actions of amphotericin B. Rifampicin, it will inhibit the nucleic acid synthesis. So it will help in the potentiation of the amphotericin B. And nephrotoxic drugs like aminoglycosides, vancomycin, cycloserine, third generation cephalosporins, they will potentiate the renal toxicity of the amphotericin B. These are the drug interactions. Coming to the topical. With this, amphotericin B is completed. The other group of drugs are the polyenes are topical polyene antibiotics. Those are nystatin, harmycin, and natamycin. Coming to the nystatin, nystatin is a fungicidin. The other name for nystatin is fungicidin. Its name is based on a laboratory, New York State Health Laboratories, where it has been developed. It is obtained from the Streptomyces norsei. Structurally, this nystatin is similar to amphotericin B with the same mechanism of action, but more toxic. Because it is more toxic, could not be used systemically. So it is used topically. It is not absorbed on oral or topical administration. Available as cream, ointment, and powder form. The uses of the nystatin is, this is used only for cutaneous infections and vaginal candidiasis. The dose is 1 lakh unit twice a day. Second one is the diarrhea due to candida. The dose for the treatment of diarrhea due to candida is 5 lakh units or 250 milligrams thrice a day. Third one is the conjunctival and corneal infections. For conjunctival and corneal infections, it is used as ointment. Coming to the next topical polyene antibiotic, that is harmycin. This harmycin, its name is based on an institute, Hindustan Antibiotic Limited, Pune, where it developed. It is obtained from Streptomyces pimprina. Pimprina is a place. Streptomyces pimprina. And uses of the harmycin are for oral, cutaneous, and vaginal candidiasis. And it is also used for the otomycosis due to aspergillosis. Aspergillus. Third one is the trichomoniasis. Coming to the natamycin, it is a broad spectrum antifungal agent used mainly for vaginal candidiasis and trichomoniasis. With this, I have completed part 1. So, on first, I will deal with the part 2 of the chemotherapy of the fungal infections. The remaining drugs I will deal with the next class. Thank you so much for listening the class patiently, and I have done this class because of the support of our HOD, Dr. Raju Devide sir. He has supported me, encouraged me, and helped me a lot for bringing this online class. Thank you, one and all. So, ఇలాగా కూర్చొని చెప్తారని